Ari. This is my patient Chris, and I'm going to be showing you how to do a respiratory assessment on him today. First of all, I've washed my hands, and I've explained to Chris what we're going to do today, that we're going to do a respiratory assessment, and I have him with his shirt off and no gown because that would interfere with using the stethoscope. And he is okay with everything. He has given consent, and we are good to go. So first of all, I would do the inspection of his chest. So I would look at his skin color. First of all, everything looks good. No wounds, no bruises, no swelling anywhere. Hair distribution is normal. No cuts or bruises or patches of redness or anywhere. We would also want to look at both hands for any clubbing of the fingers or any cyanosis, and we want to check his capillary refill. So that's looking good there, and we want to make sure that we're checking both hands. That looks good. No issues. Skin temperature is fine. He's not clammy or anything like that, not sweating. We want to look at the shape of his chest as well. Everything looks pretty symmetrical, and his costal angle is fine, less than 90 degrees, so that's normal. And looking at his breathing, we can tell that he's breathing pretty normally. He's not struggling to breathe. He's not using any of his accessory muscles up here. He's not pursing his lips or having any trouble breathing or struggling at all. So his breathing, everything appearance-wise on inspection looks normal. So now we're going to do thoracic expansion. So we're going to ask you to just turn around in your chair. And this is asked to be done at the 10th rib. So if you could just lean forward and put your arms on your knees. That opens up the scapula. And if you feel where the scapula ends, that's normally around the 7th rib, and we want to do this at the 10th. So you can feel down. So we got 7, 8, 9, 10. So we want to do that about here. So Chris, I'm going to ask you to take a nice, slow, deep breath. Okay, and just one more. Okay, so expansion looked good. It was fine on both sides, symmetrical. Both sides ended up moving together, so that looked fine. And now we're just going to palpate some of the thorax. Might as well continue on the back since we have his back here. So just measuring up here, you can feel we have the scapula. This is where we would do a lot of our auscultation, and our percussion is in this area here between the scapula and the vertebrae, because that's where it's going to be opened up. We ask the patient to lean forward because that gives us a better opening here to be able to hear the lungs. You can palpate here using your C7 here, which is the most prominent bone, and then you can work your way down to be able to feel each vertebrae to count your ribs, or you can also use your scapula to give you a landmark as well. And so you can feel all that. Palpate, you can feel the ribs down here as well, your floating ribs, number 11 and 12. And also something to note is that on the back is where we would listen to most of the lower portion of the lungs, or the lower lobes. Upper lobes are going to be hidden mostly by the scapula here, so we're going to get a good listen of the lower lobes here. On the front, we would hear mostly the upper lobes best. Okay, I might as well do some percussion here as well. So we would start up here. We're going to use the middle finger. You can just press the middle finger, or you can press the whole hand to get some more stability. And you want to use your 2 fingers and just touch or tap the upper part of your middle finger. And you want to listen for resonance or dullness. So resonance is what you should hear when you're going over the lungs because there is just air. Dullness would be over a mass, or for example, if you're over a rib or over the liver or an organ. So we're just going to do some of that over our landmarks. So doing it over the intercostal spaces here, I'm hearing no dullness, just resonance. Okay, and we would do that on the front as well, but we're not going to do that for the purpose of this assignment. And then I will start doing some auscultation. So I'm going to get you to turn around and we're going to do the front. So I will use my stethoscope, make sure we got it all warmed up for the patient. Warm up our hands, we should have done that in the beginning as well. And we're going to listen to the trachea first, so palpate the trachea, just sit up, chin up. Really easy to find, pretty prominent there. And then the subclavicular notch would lead out to our clavicles there, so we're going to use that as well. So for our tracheal auscultation, I'm just going to place the diaphragm of the stethoscope over the trachea. I'm just going to get you to take some deep breaths, fairly slow deep breaths, in and out with your mouth open. Oh, it's very loud. Okay, and then we're going to do just above the clavicle, so in again. In and out. Then we're going to do the bronchovesicular, which is going to be at the second and third intercostal spaces. So you just move down from your notch, find the angle of Louis, move over, and we got one right there. So go ahead. Okay. In. In. Okay, and then we got our vesicular, which is just going to be down again. Okay, and again I can notice that as I went down, the less clear the sounds were. That is because it's much easier to hear the upper lobes in the front. Your lower lobes you're going to get mostly in the back. Your right lung is going to have the middle lobe, which you would be able to hear under the axilla. And yes, so we could repeat that on the back. We're not going to just for the sake of this exam, but we would, like I said, repeat that for the lower lobes on the back using our landmarks and comparing both sides. And that's our respiratory exam.